Okay, great. So basically, I'm going to talk about surfactant, steroids, and pulmonary vasodilators as a sort of auxiliary therapies for ARDS. And obviously, as you can imagine, we have not very many data in pediatrics about that. So I'm forced a little bit to take some data from adult and even from the neonatal experience to cover these topics. And some of that you may find in this review. I published it almost 10 years ago, and it's very pity to say that there is not very much of evidence compared to 10 years ago. So that's a field that, you know, it's still struggling a little bit because probably not enough patients to do very high quality randomized controlled trial, despite for some of these interventions, there is quite a strong background behind. So I can only refer you again and again to the ESPNIC PEMVIC recommendations for everything about mechanical ventilation and monitoring, although these drugs are not covered by these guidelines, but I'm sure Martin said something more in detail about that just a few minutes ago. And as you know, we now have definitions for ARDS at any patient's age, so for adults, for children, and even for neonates. And this is really the first step to use in order to optimize the treatment of these patients. So having said that, let me go straight towards surfactant. So surfactant has a very long history, and we all know that when you have a patient with ARDS, you almost unavoidably have surfactant damage, which is both quantitative and qualitative, but is also linked to very high lung tissue inflammation and endothelium and epithelium injury, depending on the type of ARDS. So again, the largest experience about that is coming from neonates. And if you take the meconium-induced ARDS, so the meconium aspiration syndrome, which is a sort of a archetypical type of primary direct aspiration-related ARDS, you'll find from these data, that's one of the most recent meta-analysis, that actually a surfactant has a positive effect, both in terms of duration of hospital stay and mechanical ventilation, but as a bolus, and no effect on mortality. Why so? Because anyway, if you give surfactant this way, there will be still a lot of surfactant injuring agents over there, so able to injure exogenous surfactant exactly the same way they did for the endogenous surfactant. So anyway, meconium-induced ARDS is a sort of a primary surfactant. And it's very nice to see that on the other side of the spectrum, in terms of patient's age, adult critical care physicians, they found exactly the same. Because, for example, this subgroup meta-analysis from Dr. Toad back in CHEST 2008 subdivided patients who were receiving a synthetic surfactant in a randomized controlled trial. And you can clearly see from this data that there is a sort of a separation here, and you start to see a signal in terms of oxygenation improvement when you look at the severe primary ARDS patients. So it seems that those are the ones that can benefit the most for surfactant. And it seems a little bit logical because anyway, the direct lung injury, the direct ARDS is something with an inflammatory process is primarily localized into the lung, and you can somehow overcome with surfactant, provided that you have enough surfactant, the right dose, the right delivery, and many other things that we don't know yet. Conversely, the indirect or secondary surfactant that can actually have a extrapulmonary inflammatory trigger and focus obviously cannot be overcome, because if the inflammatory process is still there, will still be reaching the lung, injuring surfactant and the epithelium and the endothelium. And it's nice to see that even Dr. Wilson some years ago found the same in a very I would say famous randomized controlled trial that got published in JAMA 2005. And you can clearly see the difference in oxygenation and even in the mortality for those children treated with calfactant, which is not even the best surfactant in terms of composition, compared to placebo. So we go back to neonates again. And if we think in terms of lavage, not in terms of bolus, so in terms of a technique that actually allows surfactant to remove surfactant injuring agents, first of all, which is something that seems logical when it comes to primary direct ARDS. Well, if you do the lavage, you see the diamond is on the left, and you actually have a reduction in ECMO need and or mortality, which is something new because surfactant bolus did not achieve that in neonates with primary meconial-induced surfactant ARDS. There is also another nice study that has been done in an experimental model of meconium-induced ARDS. You can clearly see here that lamps randomized to have both the surfactant lavage plus followed by a surfactant bolus, they have an increment in PaO2, so a better oxygenation and even an improved compliance. So this could be actually a strategy which is very much physiopathological sound, because first of all, you remove the injuring agents and then you replace surfactant. And this is something that we could think about, but obviously it's very much experimental, and there is nothing in terms of randomized controlled trial, particularly in PICU kids, to promote that. What I can tell you is that some years ago at the ESPNIC, we tried to focus a little bit about all these, and we reviewed all the data available from the randomized controlled trials in kids and then even in neonates. And you can clearly see that there is more green than red. So there is a signal anyway, meaning that surfactant in PARDS, although these trials were done with a lot of biases and problems, and don't want to talk about that because it would be really too long, but please trust me, there are a lot of biases and flaws in these trials, but still you can clearly see that surfactant is going to increase oxygenation, maybe even others outcomes, and also mortality. So this is something that is telling us that, first of all, we should not put surfactant into the bin and think about that as a sort of a rescue therapy, and also that we should aim to have better design and more explanatory, less pragmatic trials, because all these trials actually mix in a little bit of everything. So primary with secondary, different type of patient, different type of ages, different types of surfactant and doses and administration. And it's a pity to say that even from the neonatal world, we're not going to have a lot of help in this regard, because trials about the use of surfactant in NARS have been limited by the fact that the NARS definition only came out in 2017. So anyway, surfactant has been trialed, particularly in small infants. Why so? Because infants are something in between and are a little bit similar to neonates. So since we are supposed to know what is the right dose for neonates, we can extrapolate and say that we could use more or less the same surfactant dose for infants. So it's just a sort of a, you know, comfortness about that, which is not very much well grounded, because nobody did correct dose finding data for infants or even toddler and children later on. But this is it. And so surfactant has been trialed quite a lot for infants. So what is the most common, if you want, type of respiratory failure or respiratory disease in infants? Well, very often is bronchiolitis. So many trials focused on bronchiolitis and then on ARDS secondary to bronchiolitis. So sort of a bronchiolitis is actually worsened up to give a wide lung, and so an open ARDS. So in this setting, you can clearly see again the diamond is on the left. There is an improvement in mortality, there is an improvement in ventilator-free days, and there is also an improvement in PICU stay. And this was back in 2007, but another meta-analysis from a Cochrane group actually confirmed exactly the same a few years ago. And this seems to be a quite hot field, because in Italy, some colleague of mine, they started a pretty well-designed, randomized, multi-center trial about the use of surfactant from bronchiolitis. I would say severe bronchiolitis, but then if you look at the protocol, this is practically an ARDS induced by bronchiolitis, and we will see what this data, when this data will come out from the Surfabron trial. So what is the best surfactant that should be given? Here, neonatal data can help us. You know that there are many surfactants in the world, and you can see meta-analysis there from my group in 2019. The composition is very different, but now we know for sure what is the best surfactant, and it's the porcine one, at least for two reasons. First of all, because the concentration of active phospholipid is much higher than any other surfactant, and also, so the dilution is less, and also the concentration of surfactant proteins, particularly the hydrophobic one, the SPB particularly, is much higher than any other surfactant. I cannot talk about that because there are a lot of biological data about the superiority of porcine surfactant on others, but I can only tell you that from a clinical point of view, there is a huge effect. You see the diamond is on the left again, and in neonates, the porcine surfactant over all the others is better in terms of bronchopulmonary dysplasia, but also mortality, redosing, pneumothoraces, all the acute outcomes. And this is when you treat only the primary surfactant deficiency, so a much milder disease. There is no reason to think that this is not going to be the same when you treat ARDS, which is a much worse disease when the lung is much stiffer and unfortunately much injured. The reason is very clear, as you may see here from the American guidelines. Again, it's about the concentration of phospholipid and the concentration of proteins. And so to close this section, I can only tell you that there are still some open questions, like we don't know exactly the dose to be given to children. We don't know exactly the schedule, the way and the technique of administration. And we don't know what can be the effect of newer enhanced, so more active surfactant. There have been quite a few in the pipeline, but we do not know yet. Conversely, we know that a surfactant has some effect on severe ARDS, particularly for babies, well, for children below 1 year of age and 10 kilos. And the best one to be used is obviously the porcine, which is the highly concentrated one. So we move to the steroids. And since we were talking about surfactant, I want to start with this very simple case series from Turkey, where surfactant has been admixed with budesonide to treat ARDS. The first one was a bronchiolitis, so was a RSV infection. The second one was a meconium-induced ARDS. I think that the pictures speak for themselves. It's only a case series, so obviously there's not very much of evidence. But this is very much intriguing because we now know that anyway, poractant, even the porcine surfactant, can be inactivated by ARDS mechanisms. And it does not include any particular surfactant protector. So if we think in terms of enhanced surfactant, we should actually want to have, we wish to have a more enhanced surfactant. And one of the ways to get a protected and enhanced surfactant would be to use surfactant, mix it with budesonide, mix it with a steroid or other drugs that are still on the pipeline. So the Turkish people did exactly that. And it's just food for thought for now, because it's just a case series. But it's also true that, again, in the neonatal experience, the use of steroids, both intravenously or nebulized during meconium-induced ARDS, allowed to reduce the inflammatory markers, as you may see here, and also the duration of ventilation, duration of ICU stay. Well, again, this is just meconium aspiration syndrome, so a particular type of primary ARDS. But that's the best that we have, and we could eventually, let's say, apply to other types of primary ARDS, even in children. But anyway, even for that particular type of primary ARDS, you see the diamond is on the left, reduced duration of hospitalization, reduced duration of oxygen support, but no effect on mortality. And in fact, back in 2012, we summarized a little bit of the evidence about that. And you can clearly see that, yeah, there is a sort of a B evidence for meconium-induced ARDS in neonates, but that's what we have. And also, there are only a few case series in bigger children, so in pediatric ARDS, describing some effects, a little bit like the ones that I showed you with budesonide, nothing more. And unfortunately, after 10 years, I can tell you that there is nothing new in the literature, or nothing so new. The only thing that I can show you is coming from the adult world. It's just been published in ICM, big meta-analysis about all the trials on intravenous steroids for ARDS. I'm sure that you know the trial of Villar and co-workers in Spain, published in Lancet 2020. And you see that when you put all this data together, the diamond is again on the left. So there is an effect on non-COVID ARDS patients, but this is in adults. And particularly, there is an effect when the steroids have been given for more than 7 days. So not just one shot, but a prolonged therapy, which makes sense because if you start this therapy as a sort of a rescue therapy for the more severe ARDS, you better continue that in order to try to have an effect rather than waiting for an effect with just one dose. A recent network meta-analysis also tells us something more. because, as you can imagine, there is a high variability regarding the steroids in the adult randomized control trial. And so the effect, both in terms of hospital mortality, ventilator-free days, or duration of, duration of ventilation, or incidence of infection, actually depends on the type of steroids, the dose that has been used, and obviously the type of patients, the type of ARDS we are treating. So, you know, it's very difficult to give a firm recommendation about that, because obviously all these factors are somehow creating a noise, preventing us to give you any firm recommendation. So now let's move about the pulmonary vasodilators. First of all, a little bit of pulmonary biology, because we do have a lot of pulmonary vasodilators, and each of them is acting through a different pathway. For example, the nitric oxide and the PDA inhibitors are acting through the CGMP. The nitric oxide is increasing the CGMP, and the PDA inhibitor, they're actually reducing the breakdown of CGMP, so increasing the level of that secondary NO messenger. And then we have the bosentan and the tezosentan, who are inhibitors of the endothelin-1 pathway receptors particularly. And then we have the prostacycline, and particularly the iloprost, who is increasing the CAMP, exactly like adenosine, was being used quite a lot by Peter and the Geneva group a few years ago. So you see, these drugs have actually different pathways of action, which also means that they could actually have synergies between them, which is very much interesting to be remembered. And I would say even not so exploited, not very well investigated so far. So a few months ago, we published this protocol. As you may see in this picture, we provided you with a sort of a map with all the interaction of these drugs. And you can clearly see that some of them are synergic. So you have an interest to use the ones that are crossing each other with a green square, because this way you can have a synergy and possibly lower the shunt fraction and the pulmonary hypertension related to ARDS when just one of these drugs is not actually functioning. And we actually do that for kids, for neonates, at the border of ECMO, trying to reduce the need of ECMO, but this is only because we have ECMO very close round, and you should be very careful to use all this pulmonary vasodilator if you do not have ECMO. I mean, if you have ECMO, because you shouldn't delay ECMO. Obviously, if you do not have ECMO, you are a little bit more free to use these drugs. But anyway, a correct protocol and procedure for ECMO referral should always be in place and enforced. So iloprost is the one that we use the most as pulmonary vasodilator. First of all, because of this synergies, but also because Peter demonstrated more than 20 years ago that actually has the same power than nitric oxide, as you can clearly see from this paper from Circulation 2001, and also because it's very manageable, as a quite short effect time. So you gotta nebulize it every 2-3 hours, but it's very easy to be nebulized. There is absolutely no side effect in terms of systemic pressure and in terms of any other side effect, and it's also quite cheap. So we use that as a rescue for NO for several cases, as you may see here, and it's something that has been studied quite a lot by Peter's group some years ago, as you can clearly see from this Swiss meta-analysis. But then again, even with the meta-analysis, you can clearly see that the majority of studies about the use of iloprost have been not controlled, not randomized. So the evidence is pretty low, but it's very manageable, and we use it with a high frequency membrane nebulizer that you can clearly see can be applied even in high frequency ventilation. We now have many data that I cannot show you, but particularly coming from the de Blasi group in the US, demonstrating that this type of nebulizers are able to nebulize iloprost effectively, even during HFOV, which is something we didn't know like 10 or 15 years ago. And then the interest of iloprost is also that since it can be nebulized by this type of nebulizers, you can even use it in a non-invasive way for those patients that you can actually try not to intubate as much as possible, like the immunodeficient one, like the oncological one, or like, for example, the infants and toddlers with bronchopulmonary dysplasia, like this one, as you can see. Because obviously, when a patient like this one have ARDS because of RSV, because of flu, or because of anything, the last thing you can you want to do is to intubate him, because then it's going to be very, very difficult to extubate him. You can clearly see the film. And when we use in a pretty large case series, but it's still a case series, when we use the alloprost in conjunction with NEVA non-invasive ventilation for this type of babies, you can clearly see here that we achieved an improvement in PF ratio, and also we achieved a decrement in the ratio between pulmonary and systemic pressure. So, you know, re-establishing a good hemodynamics for these patients. And also the comfort in terms of respiratory rate and heart rate was pretty good. It's nice to see that a similar uncontrolled experience has been published more recently in adults with ARDS. And you can clearly see that the oxygenation was going up with the alloprost nebulization, and the systemic mean arterial pressure was absolutely stable, was flat. So there is no systemic effect of alloprost, as I told you a few minutes ago. And the adult and the neonatal data are going towards the same direction, are very much consistent. And this is the best that I can tell you for children, because again, unfortunately, the very pediatric population right in the middle, it's a little bit scanty of data about that. Here is another trial, very short, very small, but it's a crossover trial actually. So at least it's sort of randomization in adults with ARDS. And here you can clearly see that the increment in oxygenation seems to be there, particularly for less severe patients in terms of compliance. So those patients with a less stiff lung. It seems logical to me in terms of physiopathology, because obviously alloprost is acting, is improving oxygenation by reducing the shunt fraction. But if you have a part of your oxygenation deficit coming from the actual parenchymal disease, because your lung is very much stiff because of the inflammation and because of surfactant injury, while it's not the pulmonary vasodilation that is going to improve the problem until at least you open up the alveoli with a good high frequency ventilation or pronation, or the combination of both, or whatever. So when you achieve a good recruitment and so a better compliance, then the alloprost can be an additional tool to increase your oxygenation. There is actually now a phase 2 trial that is ongoing for alloprost in adult ARDS, which is very much interesting. It's a European trial that you can see here. I don't know where the results will be available, but that particular trial is actually exploiting alloprost not only for its pulmonary vasodilator effect, but also for its new anti-inflammatory effect in the lung. So it is totally new. We'll see what is going to happen with that. For now, I can only tell you that ESPNIC issued some guidelines about pulmonary vasodilators in 2004. We never actually renewed these guidelines later, but according to what I showed you so far, actually there is no very big news. So according to these guidelines, nitric oxide is obviously the first-line therapy, both for neonates and infants. I didn't say very much about nitric oxide because I assume that you already know, you have everything about that. But regarding prostacyclin in general, and so also iloprost, there is a chance that can be transiently useful, and we only have one trial in children demonstrating that in terms of oxygenation. So the guidelines are only telling you that it's something that can be tried when the patient situation is too much severe. So we stick with some open questions. We don't know exactly the dose. We don't know what type of molecules is better than any other. We use very much iloprost, as I told you, because it's very much manageable, but there is no preference, no formal preference to be given between the different drugs. Maybe for the patient selection, it's better to use iloprost when the patient has already been recruited, as I showed you before with this data from adults. But again, no pediatric patient data, and we don't know anything about the duration of the therapy to be applied. I can only conclude suggesting you to become an ESPNIC member. We're going to work about this area and many other, and even more. You know that ESPNIC grew up quite a lot in the very last years, And hopefully in the future as well, we have more than 20 key euros of research grant per year. We're going to launch a new journal, which is called Pediatric and Neonatal ICM very soon. And we have a lot of simulation training at our face-to-face congress is going to held in October in Barcelona. And the next one will be in Athens 2023. And you are more than welcome. Thank you very much for listening to me.